So Kevin, would you mind just introducing yourself one more time, just name and who you are?
Kevin Smoky Day, elder in residence. I'm from Treaty 4 territory in Canada.
You, Dr. Robbie?
Yes, hello, I'm Kari Rabi. I'm a family practice and addiction medicine physician. I've been working here at NACC for over 10 years, and I work closely with the MAC program.
And Tina? Oh, Tina, are you there? See you.
Yeah. I'm Tina Monnier, the harm reduction manager here at NACC.
Thank you. And I'm Lindsay King-Cooney. I'm the community and tribal engagement specialist here at NACC. We're missing two of our other ECHO members. We have Michelle Corcoran, who is our MAT nurse manager, and Nikki Giardina, who is our infectious disease nurse. So I will get started with a few announcements. I'm going to share my screen. So welcome everybody to the Midwest Tribal ECHO. Today we have Dr. Ntaba. He's going to be presenting on biological basis and bedside manner in opioid use disorder. A little bit about NACC. So we're the Native American Community Clinic. We were established in 2003 as an FQHC. We're located right in the heart of South Minneapolis in the urban Indigenous community. This is a list of all of our services that we provide. Our website at the bottom if you'd like to learn more. This is a list of all of our open positions at NACC, and as well you can go to our website and read more about those. Some session guidelines. Please know protected health information. If you could mute yourself when you're not speaking. Please let us know who you are in the chat function. So your name, title, organization, and email. That helps us to know who participated and who I should send the post-evaluation survey to. And then if you could turn your camera on if you're feeling up to it, we'd love to see your faces. Some announcements. So our next ECHO session is going to be September 20th, and that's with Dr. Sandra Comstock, and she'll be talking to us about her program, Hygiene for All. And then October 4th, our clinic will be closed for an all-staff cultural event, so we won't have an ECHO on that day. This is a list of other ECHOs that cover opioid use disorder and other topics relevant. We have Hennepin Healthcare, Indian Country ECHO, and Stratus Health. We do offer continuing education credits for those who are eligible. So we just ask that you fill out the post-evaluation survey, which I'll put in the chat, and then also email after the session. This is just a reminder of the X waiver removal. The CME credits from these ECHOs do count towards the 8 hours of training that's needed to prescribe Suboxone. And then case presentations, if you have any presentations that you'd like, please email me. My email address is at the bottom. They make for a great discussion. And then with that, we'll get started. Thank you for being here, Dr. Ntaba. Would you mind introducing yourself?
Yeah, hi, and thank you for inviting me. And Lindsay, just a heads up, I think I sent you an updated slide deck maybe 20 minutes ago. If you're able to check your inbox and pull that, otherwise okay. I can give a shot at sharing from my Zoom. But a little background on me, my name is Dziwe Ntaba. I'm an emergency physician, I've been practicing for over 20 years. I have a degree in public health, a lot of public health practice experience. I spent the last couple of years doing a Bush Fellowship, which allowed me to engage with community members from different groups across the metro, really, explore patient experience related to opioid use disorder. I did a site visit out in Oregon, had a chance to talk to some national thought leaders in this topic. And I want to talk to you today about, I always like to frame these conversations with the biological basis of disease when it comes to OUD. but then also what I've learned about patient experience and how that biomedical framing helps me understand, behaviors related to addiction and some of the patient experience as well. So while we're waiting for the slides, just as review for the biological basis of disease, I think there's a lot of unfortunate misunderstandings around, moral failings or other lapses that drive addiction. But as an ER doc who has been seeing patients, I have renewed my belief in the biomedical disease, the basis. So if we think of normal brain function, most of us who've never been exposed to opioids will live our daily lives with some fluctuation in hormones like dopamine or endorphin. On a normal day, our dopamine levels might be around 50%. If we think of a dimmer switch analogy, most of us are around 50%, give or take. On the best day of our lives, if that's, say, childbirth or favorite meals, brain without opioids, we can dial that dopamine level, that dimmer switch, to close to 100%. On a bad day, if we're not feeling motivated, don't want to get out of bed, we're maybe at 40, 30%. That's the normal expected range of brain chemistry, right? When the brain becomes exposed to synthetic opioids, especially the high potency fentanyl nowadays. If we could advance to the next slide, Lindsay. Then that dimmer switch will go up to like 1,000%. Totally unnatural, totally artificial release of dopamine. It's one thing if you have a bone sticking out of your leg, you've had major trauma, and you get the opioids, then pharmaceutical fentanyl or morphine will act to relieve pain, right? You might get some euphoric effect, but the main activity of that drug is pain relief. But if we're not in pain, if we're maybe misusing, then it acts, especially the synthetic circulating on the streets, it acts in a different part of the brain. And the effect is mostly euphoria, calm, intense reward. And if you think of somebody who's maybe living a stressful life, chronic, maybe either poverty, discrimination, maybe traumatic, those are all traumatic experiences. I can better understand why someone might reach for that instant relief in a pill, right? The problem is those euphoric effects start to wear off rather quickly. The mechanisms that we talk about, like with tolerance or dependence, these are biological changes in the brain where we have things like receptor upregulation, downregulation of the body's ability to produce dopamine and endorphin. So each subsequent, maybe on day one, there's that 1,000% dopamine level high. On day 3, day 7, that euphoric effect starts to decrease with a tolerance in the brain. And then at a certain point, the brain stops making our own chemicals and hormones. So someone becomes dependent on that synthetic opioid, right? When we become dependent, then anytime that opioid is not in our system, we have these withdrawal effects that are physical, emotional, psychological. The cravings that we talk about in opioid use disorder is not just like I really want to get my favorite sandwich. It's like, I haven't had water in 3-4 days, and I need this to survive. It's staggering level of changes in the brain drive these behaviors like cravings, and I think that drives a cycle of disease when we think about addiction. If somebody's selling their grandmother's, furniture, doing something that they would never previously have thought to do. They're doing that because their brain is telling them that they need this substance to survive. If they don't have that, they're in survival mode, fight or flight, itself a traumatic experience, right? And so that's reflected, that pattern is reflected in these lines across the chart here. If the normal, normal brain activity is that gray bar in the middle, the euphoria and the elation are the dark gray bar at the top, and then the withdrawal syndrome is the blue bar at the bottom. That cycle of disease can be broken with MAT, right? With partial or full agonist therapy. And so when I talk to my colleagues and communities nowadays, I talk about that as really a hormonal replacement. It's more complicated than that, but I mean, the effect on stabilization of the brain chemistry is the same as, say, insulin for a diabetic. If the pancreas isn't making that hormone, we replace it. I advise my patients in the same manner. Okay, next slide. That biological basis also drives this observation through data here. So we all know one of the side effects of opioids is respiratory depression. People stop breathing. They need Narcan, resuscitation. We all know that Narcan drives people into fluoride withdrawal, right? Some of the worst withdrawal that they've ever experienced. They spend their daily using lives trying to avoid this experience. The aversion to the withdrawal is greatest with these synthetic opioids. The highs are higher, the lows are lower, the aversion is stronger. And what we're seeing, this is emergency department data, people who are treated for non-fatal overdose, so that's naloxone rescue, their chances of dying within the first, there's a spike in fatalities after exposure to Narcan resuscitation. At first, when I trained 20, 30 years ago, I thought this was due to maybe rebound overdose. But I think we now better understand this is most likely driven by the nature, the extent of withdrawal that a patient experiences after Narcan rescue, to the point where they're going to run out the door and want to go use again to fix that problem, right? And we now know that we can intervene with a dose of buprenorphine on the heels of Narcan rescue in order to blunt that severe withdrawal state, and I think intervene and avoid these spikes in fatality. I imagine this is true. This is emergency department data, so it's easy to follow people, but this will also be true for folks given Narcan in the community if they don't transfer to care, bystanders. So part of our Narcan education now is someone's not out of the woods yet just after the Narcan. They need to, at minimum, be aware of the risks and ideally get started on a stabilizing medication. Next slide. The volume of synthetic pills coming into the country is just skyrocketing. So 2018, about 300,000 pills seized by law enforcement. Up into 2021, that increased to 10 million. I just looked at the data from the DEA website last year that went up to 50 million. So we're seeing this exponential increase year after year on the supply side of the problem. At the same time, next slide, that we're seeing a decrease in the number of folks seeking treatment. I think across the board, population level statistics are very low. Maybe 10% of all people with substance use disorder seek treatment. This graph looks at Minnesota data and American Indian population compared to the rest of the general population. You can see those numbers seeking treatment at a higher level and increasing up until about 2016, 2017, and then a decrease thereafter. So we're seeing higher supply, higher disease burden, with lower entry into treatment across the board, but particularly in this population, Minnesota. Next slide. We all know the harms associated with opioid use, the health responses. There's a lot of focus on harm reduction. Finally, within the last few number of years, my focus as a practitioner in the emergency department has been on trying to expand access to treatment, engagement with, and access to treatment in a culture of harm reduction. So if people aren't ready, we give Narcan and refer to harm reduction resources, but really trying to engage more people in treatment in the emergency department. And we know from this JAMA article review is a couple of years ago in the middle of the pandemic, but the best intervention study in that review article for reducing overdose was engaging people at MAT. So our, at the University Medical Center, where for the last 6-9 months or so, we've been trying to really aggressively provide access to MAT buprenorphine in our context in the emergency department. Next slide. We all know the benefits on an individual level, the survivability of MAT over a 5-year period is tremendous compared to the general population. Untreated OUD, there's a 6-fold increased likelihood of death in 5 years. Of that population, treated OUD patients on MAT increase their survivability, all-cause mortality, by close to 70%. Next slide. So I just wanted to drill down a little more on the molecular level of some of these observations. So talked about how opioids develop or lead to tolerance and dependence, right? That's through upregulation. If the cartoon graphic on the right here, purple cone is the opioid receptor. The pink line on the bottom is the brain. The green spiky ball is the synthetic opioid. Unfortunately, manufactured to be a perfect fit at that receptor. So overrides all natural occurring like endorphins. Upregulates, meaning the number of receptors. The brain adapts by increasing the number of opioid receptors because that's usually an on-off activation and the body is not making their own. So there's the brain's thirst for opioid increases, and that's manifested through the number of receptors, right? Not only that, the receptors themselves become less and less activating. And that's the molecular basis for tolerance and dependence. Next slide. Once that synthetic opioid is withdrawn or dissipates or wears off of that receptor, empty receptor sends this signaling cascade, really, that involves pretty much the full body nervous system, central and peripheral. That's the pain signaling of an empty receptor is very pronounced, but effects on the GI tract, nausea, vomiting, the fight or flight kind of agitation and traumatic stress, or stress hormones. It's all driven by this empty receptor. Buprenorphine, as we all know, partial agonist, right? But a tight fit or high affinity. So the bupe can cover that receptor, outcompete the fentanyl. Because it's a partial agonist, you don't have the same, in an opioid tolerant patient, if they have dependence and tolerance, then the bupe isn't going to activate at the same rate as the fentanyl. So people don't feel high. They might have a little euphoric effects until we get the dosing right, but people, it's legal to drive on bupe. It's a very different interaction. So in that manner, it's enough to treat and prevent the withdrawal symptoms, without because it's a partial activation, without the unwanted side effects of, say, respiratory depression, or euphoria, sedation, that type of thing. Next slide. There's also a blockade effect that I think is equally important, especially in our patients in the emergency department. Say post-overdose, we want to treat their withdrawal symptoms quickly, and we can do that with loading on buprenorphine at therapeutic doses. So within an hour or two, we can get someone from the depths of withdrawal to feeling much better again. Might take another day or two to really normalize, but it's a great tool for us in terms of acute withdrawal management. But then there's also a blockade, meaning if someone is on buprenorphine and they go and use again, maybe they go home and there's a dealer in the same building, they've got the bupe on board. If they use again, they're protected from overdose. So the blockade and the partial signaling, the partial agonism, are both two extraordinary benefits that I think help explain the benefits for mortality reduction and life-saving nature of bupe. Next slide. That also, I think, explains this data, which I haven't looked at the article in a while, but it is a comparison of buprenorphine and naltrexone, either injectable or oral forms. And it looks at the rates of overdose for people who are on buprenorphine compared to people who are on naltrexone in those two different forms, compared to people who aren't on any MAT at all. The blue bars are people who are currently taking the bupe or the MAT, and the green bars are people who have stopped their formulation of MAT within the last 4 weeks. And you can see that the lowest number of overdoses are in people who are on the far left, people who are maintained on their buprenorphine, right? That's the smallest blue bar. People who are started on buprenorphine and then relapse, there's still some residual protection. I think partly because of that blockade initially, but also because of that agonism, it preserves, I don't want to misspeak here, but bupe partial activation will maintain a level of tolerance, so that if someone relapses, they're less likely to overdose, as opposed to someone who, say naltrexone, which has no activation. People will lose their tolerance very quickly. If they relapse, they're more likely to overdose. So I think that all ties to the biological basis that we've been talking about. Next slide. So in the emergency departments, there are emerging paradigms, I would say, in different parts of the country that we're learning from locally, and that we've had some success in moving towards. So as of 2-3 years ago, the patients I saw in the emergency department, I was starting in our conventional protocols. I had a chance to, because we at Riverside Emergency Department, we have a walk-in recovery clinic next door. So I could most of the patients I would refer over there, I'd be confident or I'd be comfortable thinking that they should show up on my same medical record, right? But what I was seeing, it just anecdotally, but a few dozen patients, even if I started them on bup in the ED, I wasn't seeing them in follow-up in a recovery clinic. So we started looking at these high dose inductions, getting people therapeutic right away. And unfortunately, I'm just going to minimize the faces here to reveal the diagram on the right. But basically, the benefits of high dose starts or macro inductions in the emergency department setting, it's rapid same day access we can provide year round, around the clock. So we're striving to become a treatment access point, kind of on demand in our emergency department, and there's others in the metro area that are also engaging this. The challenge is patients need to be in at least a moderate amount of withdrawal or severe withdrawal. The diagram on the right, if those blue squares are opioid receptors and the red circles are the fentanyl, and the green circles are the buprenorphine. Let's say a patient took fentanyl maybe 2-3 hours before coming into the emergency department. I would expect them to have all of those blue squares, receptors, saturated with red circles or fentanyl, right? So that is someone who is not going to be displaying any withdrawal symptoms, and they're not ready for high dose induction, which is different from the microdose protocol. Again, a simplified diagram, but basically the person needs to be in at least a moderate amount of withdrawal or a predominance of empty opioid receptors in order to receive the buprenorphine and have a successful induction. If there's, if most of those blue squares are filled up with red circles with the fentanyl, then the bup will still work, but because of the partial activation, someone will go from a full agonist predominance to a partial agonist saturation, and that's perceived as a severe, that's perceived as precipitated withdrawal. Just that jump from full agonism to partial agonism. But if they are in moderate or severe withdrawal, if you have a predominance of empty receptors, then adding that buprenorphine, there's only then they can only get better, right, with more partial agonism. And so that's the kind of rule of thumb, or the mechanism that I think about when interpreting someone's symptoms to decide if they're ready for buprenorphine. We also advise people to, if they're not ready in the ED, we'll send them home. We've now switched to high dose starts in the outpatient setting. The trick here is the elimination of fentanyl is highly variable. Some people will metabolize within 14, 16 hours rather quickly. Other people will take 2-3 days before they're in a moderate to severe amount of withdrawal. And so the advice I give to patients is you just have to wait until you're feeling very dope sick. They need to hit that physiologic withdrawal threshold. If they're in the emergency department, that's easy to, if they're in front of you, that's easier to assess based on physical exam, right? Looking at pupil dilation, looking at sweat on the brow, looking at goosebumps, runny nose, watery eyes, yawning. These are all signs of physiologic withdrawal. You don't need a cow score. It's comforting to have one, but we all know, as clinicians, we all know withdrawal when we see it. And when you see it, with especially those objective findings, then we are a lot more comfortable that this patient is ready for induction. There's, as a group, I mentioned in January, as soon as the X waiver was lifted, we started having a lot of provider education. We're having more and more adopters, more and more success. We had maybe one case of precipitated withdrawal that was managed with more buprenorphine, and but largely successful, almost entirely successful high dose inductions. The common pitfalls that we're seeing, I think there's a fear, understandable fear, but I think unnecessary fear amongst both patients, almost to a person. Patients are really afraid of precipitated withdrawal. They might have experienced it themselves or heard about it from others. And then that makes the providers really hesitant because no one wants to, have someone feel a whole lot worse after they've been given a treatment than beforehand. But there's increasing amounts of evidence, including a large multi-site trial, that shows the incidence of true precipitated withdrawal with protocols that follow basically this rationale that I laid out with the diagram. The incidence of true precipitated withdrawal is 1% or less, and that's even in the setting of fentanyl, majority fentanyl users. That was published a few years ago. The citation, I think, is the first one on the bottom. So that's allowed myself and my colleagues to really have the confidence. I can now say with 99% certainty to a patient, I can get you through this. And if things go sideways, there's some people we just don't understand, but 1% or so will develop precipitated withdrawal. The treatment there is more agonism, which is more buprenorphine. And that can be accomplished with, more agonism can be accomplished with more Suboxone, so higher and higher doses of Suboxone. There is no max dose when it comes to, safety. There are side effects that can be encountered, but a trade-off of, bupe side effects versus precipitated withdrawal becomes a pretty clear decision. In the ED setting, we can also add more agonism through pharmaceutical fentanyl because we can manage critical care cases. We can do high doses like 100 mics of fentanyl, which is a rather high dose, the kind of thing you'd want to have someone on a monitor for. And interestingly, ketamine potentiates the effect. So it gives the buprenorphine a boost, some kind of receptor modulation. But those are the options that we have if someone goes into precipitated withdrawal, which I say is rare in our experience, and I think it's borne out through the data. Another common, I think, pitfall is underdosing of buprenorphine. I know at NACC, I know you guys are dosing usually at 24 milligrams more routinely, and I think, and I wish other clinics would catch up with that paradigm. What we see is, a lot of people being started on 4 milligrams, 8 milligrams. If they're tolerant and dependent on fentanyl, that's just not going to be enough. And the risk of underdosing, including at induction, is, people, I think, are at risk of overcoming from their being overcome by their withdrawal syndrome and returning to illicit use. You also lose that blockade effect at lower dosing. So for these reasons, we're switching to the high dose protocols and high dose for maintenance. It's not uncommon for us to load at 16 at a minimum. A lot of my patients will land at 24. Some will need 32. Some might even need more than that for initial stabilization, saturation, and then maintenance, usually around 24 milligrams. All tailored to individual patients and dose history. Unfortunately, the FDA package insert still has a target of 16 and a max of 24 milligrams. But there's a paper, and that's the second citation, that reviews all the evidence of buprenorphine and really makes an argument that those FDA labeling guidance are really causing harm. And we could save a lot more lives by lifting that. There's a dose-dependent effect up to 32 milligrams. I don't know if it's been, but there shouldn't be any reason for like an insurance company to deny or a prescriber to feel hesitant about dosing higher. Next slide. A lot of this has been published in shareable form by a group called California Bridge, or they're now Bridge to Treatment, that have probably the most developed and mature protocols. By mature, I mean they've been doing this for 3-4 years. And this is an example of the discharge instructions. If someone doesn't meet criteria for starting the bup in the ED, this is part of the discharge instructions. There's some very occasionally we'll see a patient who is, either addicted to prescription narcotics, or maybe they're very early in their course. So they're taking, say, 5 to 10 pills a day. Light habit, I mean, that's really kind of light disease burden, right, in terms of the neurochemical changes in the brain. But a patient like that, I think, would still benefits from the more conventional dosing, 4 to 8 milligrams, as long as they're aware that, maybe they're not being forthcoming with their use, especially if there's a family member present, that they might need to go up if they still feel dope sick after 8 milligrams. The symptoms will continue. And I think that undertreated withdrawal is a whole lot more common than precipitate withdrawal. In fact, we know that's true, but those two get conflated. A lot of patients come in and tell me their stories about having a bad experience with bup in the past. And drilling down into it, it really sounds a lot more like undertreated withdrawal than precipitated withdrawal. For people with a heavy habit, smoking their gram of fentanyl a day, those are people who I'm now a lot more comfortable starting at 16 at a minimum. We still advise 8 to 16 milligrams consideration starting dose, but it's really all based individualized on the patient's biological burden of disease, right? Okay, next slide. And this is just more example, but I highly recommend checking out the California Bridge website, or I think it's the Bridge to Treatment website, because there's a lot of very useful information that we are basically moving our protocols in that direction that the hospital I work in and the system I work in as well. Next slide. The benefits of buprenorphine, the successes, I think on a population level, can be seen in these two graphs. So the country of France in the 1990s had a bad heroin overdose problem. They introduced buprenorphine to their formulary in like 94, 95 or so. They had some incentives. They reduced barriers to access. They have a different health system there, socialized, so they didn't have some of our inherent barriers. But just with that primary intervention of adding adding a tool to the list on the formulary, they were able to reduce overdose mortality by 80% within 4 years. This was largely in the primary care setting. No training, no regulations, no X waivers. And it's just extraordinary. It's probably the best example of a opioid response that I've come across. So that red line is the heroin overdose death by year. The green dotted line up top there is the number of patients started on buprenorphine. Baltimore in the 2000s, the bottom graph, was able to see a similar inflection point, reduction, right, flattening, and then reduction in that curve in terms of number of overdose deaths. They had a slower time to reach a significant number of overdose deaths and reduction, but it was still tied to the number of patients started in buprenorphine. You can see the mirror image in both graphs. Statistically, we'd refer to that as like a correlation, that or dose response. That's very convincing evidence that the reduced number of deaths and funerals in the red lines are directly attributed to the increased number in buprenorphine prescriptions. Next slide. And if you think about the biological basis, I think it makes a lot more sense to me. These numbers are locally in Minneapolis. I think we're all familiar with the increasing numbers. The orange line is our Native American population, increasing more so than others. I mean, across the board, there's market increase, but just the difference, I think, helps us better understand the impact on the community. The thing that I worry, or the thing I wonder about, is that that difference has been there going back 10 years or more, but it was rather steady up until 2020. So 2017 kind of looked like 2018, kind of looked like 2019, and then in 2020 we start seeing this even more staggering increase. I'll go into more of what I think may be contributing to that, just based on patient experiences, but without having the community or lived experience. But part of it, we talked about that graph with increasing supply, right? And decreasing, maybe the supply is outpacing, so the supply is certainly outpacing the bandwidth for treatment. But if this is Minneapolis data, so if that's largely concentrated in South Minneapolis, and we're thinking of 2020 as a inflection point, and all the collective trauma and stress and kind of glare on South Minneapolis 2020 onwards, I wonder how much that traumatic experience has a role to play in these numbers that we're seeing. Next slide. So I'm just going to minimize the videos again here to see the full. This is 2021 data, and again, these are just comparisons of disparities. The U.S. Overall, there's observed and known disparities. That's reflected on the left. In Minnesota, the State Department, the Department of Health is really good about putting out statewide data and looking at those disparities. But I think the largest contribution of the statewide disparities, I think, is in the Minneapolis disparities. That 29 to 1 disparities in overdose deaths, and thinking that 1 is a very big number to begin with, right? For the Black community, I think it's closer to 4 to 1. But largest disparities in the country by far, and unfortunately worsening over time. But looking at these numbers, helped drive my interest in traumatic stress, and patient experience as possibly contributing factors. Next slide. There's a really helpful, informative resource called the Campaign for Trauma-Informed Policy and Practice. They put out this policy guidance a few years ago. I recommend looking at the article, but their position is unless and until we get a better understanding of the effects of trauma, and that's generational or childhood or chronic adult or societal, with pandemics and uprisings. Unless we become informed by and responsive to those effects, we're not going to be successful in addressing the opioid epidemic. Next slide. The Dr. Sandra Bloom, one of the thought leaders for the last 20, 30 years, has a really useful website linked up there, but she talks about a public health approach to trauma. So on a primary prevention or trauma-informed level, just basic awareness of both the short-term and long-term impacts of trauma, the health impacts of trauma, the isolating impacts of trauma, the physiologic impacts of trauma, I think are all examples of being informed by trauma. Understanding that, I think helps not only destigmatize, but also helps us better engage. If we talk about bedside manner, I'm going to be a lot more effective engaging somebody if I understand what's going on in their brain, what's going on a hormonal level, and what's going on in the psychosocial kind of traumatic stress space. The person registering patients in the waiting room probably doesn't need to have the same depth and breadth of understanding. But it's helpful for them to know that if someone comes in, agitated, and certainly if they're in withdrawal, or understanding that, someone's daily lived experience with opioid use disorder is a chronic and increasingly traumatizing state. I think we can, help increase understanding on the part of the hospital personnel, but I think we can provide better service, makes it less of a toxic environment for patients to come into. So trauma responsive, there are, practices and policies, and I'll talk about one in a sec. But just ways that we can change how we approach patients that are more responsive to people with traumatic stress. And then there's trauma-specific interventions, which I think are the most individualized. But, when the elder mentioned the blessing at the start of the lecture in terms of language, something like language can be used to help somebody. I think that's a great example of a culturally celebratory option. If someone has a lived experience of stigma and invalidation and structural violence on my culture, if I see validation in language or ceremony or spirituality, that's a trauma-specific intervention. Next slide. So we've...
Ntaba, sorry to interrupt. I just want to give you a time check. We have about 7 minutes before 1 o'clock.
Okay, I'll just wrap real quickly then. Our pilot at the University Medical Center is to have what we call a substance use navigator, or basically hospital personnel who can accompany OUD patients, kind of provide one-on-one bedside care. Sometimes it's light touch. We're moving towards, more concierge level, but basically a friendly face to help people understand, that we're here to help. We have options to help. If they're not ready for treatment, then we have harm reduction resources to refer to. And then that same navigator, in addition to that companionship, helps provide basic care coordination. We'd love to get to the point where if someone has a particular tribal affiliation, then we can help them plug in with certain resources. If they need to escape a chaotic living environment, or if they're unsheltered, help navigating towards a detox facility or a resource where they're also continuing MAT. And then also supporting with basic education. Our navigators will go to the pharmacy or go to we have a vending machine now that kicks out an Instimeds machine that kicks out buprenorphine. But basically something as basic as handing someone the medication, either the bup or the Narcan, really increases the likelihood that people are going to continue to take it. So I went longer than I had hoped, but any questions on any of that?
It looks like there is a question in the chat. Let's see, Mark asked, are there trained street teams going out to educate and recruit users to treatment services? I mentioned Cure Violence program out of Chicago was a street team that reduced murder rates in high-risk neighborhoods.
I'm not turn off the slides, Dr. Ntaba, just so we can see.
Oh, yeah.
Okay. Thank you.
I think that's a fantastic idea. In fact, I'm going to go visit one of the outreach workers from Little Earth at the encampment tomorrow. We have been trying to brainstorm ideas about getting people to treatment. We looked at ideas of maybe bringing the treatment to people. Logistically, it gets complicated with like mobile units and stuff. But maybe like a shuttle bus to either emergency department, or we have a walk-in recovery clinic. But yeah, what's the name of it? Is that in the chat? Because I need to look that up. The Chicago model.
I wrote it out. Care Violence program out of Chicago.
Okay.
For about 20 years, they used high-risk neighborhoods of high murder rates, reduced murder rates by up to 40% in violence. So if you watch the YouTube videos of these teams, it's just dramatic, it's striking.
Okay.
And all Black men and women, all ex-convicts. And I thought, how brilliant.
Yeah.
We'll use former drug users who struggled and failed, and many times working with, they understand it better than a white guy like me would understand it.
Yeah, thank you for that.
Dr. Ntaba, thank you so much for joining us. When you do the self-start macro dose, or even when you and you're sending people out, what is do you have any statistics on the success rate of that? Like what we find with our patients is that they have a really hard time waiting for that period, going through that period that they have to get to be in that the withdrawal level they have to get to start that. So our when we did send out people with the macro dose, they haven't come back.
Yeah. I don't know from the emergency department because it's hard to follow up, and we've only been doing this for a number of months. But I have heard that's not unique. I've heard that from other systems and clinics as well. The way I try and mitigate that is by explaining, because the anxiety and the even the pain can be subjective. And I think the aversion to that withdrawal syndrome is so pronounced, especially with fentanyl nowadays, that people might jump the gun or presumably will start sooner than having somebody, a clinician at the bedside really doing an objective analysis of the physiologic findings, the pupil dilatation and whatnot. But we try and do just more education on you have to wait until you're really dope sick. And people understand, people usually know their disease well enough to project out how far that might be.
Yeah, our experience has just been that they don't take it. Like they just cannot because there is such an aversion to the precipitated withdrawal that they can't, neither can they get to the place that they need to get to in order for it to be safe to take the medication.
Yeah.
So,
Yeah.
so the reason, I mean, we are doing the micro inductions, which is a, kind of a different approach. And so I'm curious about that, because a macro induction would be much quicker. And we do have done those. It's just as hard for people to get there.
Yeah. Yeah, I'll let you know if we're able to get any follow-up data.
Yeah.
We're still in that.
There's another question from Dave. Suggestions for effective linkage efforts in the ER when patients are leaning toward AMA, linkage to community-based groups like Southside Harm Reduction or clinics like NACC or Endeavor's Clinic with walk-in options.
Yeah, those are I didn't know about Endeavor's Clinic, but certainly Southside and NACC. We also have a recovery clinic, are options that we make available to folks. And I think oftentimes that instinct for AMA is partially driven by untreated withdrawal. We'd like to get to a point where we can offer someone like some injectable bupe on the way out the door. We don't have that logistically figured out yet, but yeah, we're always interested in more referral options. So I'll take a look at Endeavor Clinic as well.
Are you handing them a tangible paper, or is that being brought to somebody by like a peer advocate, or is that all word of mouth, or is there actual like a tangible sheet for those referrals to resources?
Right now it's in brochure form. For Southside, for NACC, we're typing into the discharge paperwork. For recovery clinic, it's sometimes we'll just walk them right over. It's literally next door to the ED. But we're still in pilot phase. So ideally the navigator gets trained up to understand. We're still doing resource mapping as well. But really understand the best tailored referral option for patients.
Thank you.
Dr. Ntaba, do you know if there's been any effort to increase the number of detox programs where you can provide, have somebody in a facility for 3 days or so and provide comfort meds or like fentanyl or other opiates to get them through in a more comfortable way the withdrawal process?
I know that 18 in Chicago is doing bupe inductions. I don't think that they're doing full agonist. Sorry, our alarm has gone off here. I don't think they're doing full agonist bridge, although I think that's legal even at the federal level. It's something we'd like to consider in the ED, but there's other. So we'll often send people to 18 in Chicago, either with meds in hand or deliver it the next day. Where else? Gateway does bupe induction, but I don't think they do induction. They do continuation. Who else? Mission and Ramsey County Detox are the facility-based options that we send folks to. I know that there's a lot of programs that are still abstinence only, and that's why we're trying to do resource mapping.
Yeah. And then just I guess for information, we've had some pregnant women who we've sent to Fairview, and they've admitted them and given an opiate agonist along with a Suboxone microinduction. So they've switched. Yeah, so they've basically done an inpatient microinduction.
Yeah, I should add, for people who have either pregnant or medical reason for admission, we're able to offer that. And Ryan Kelly's group is doing microinduction for the patient. Yeah.
Thank you. I know we're over by about 4 minutes. Does anyone have any final thoughts? Well, thank you so much, Dr. Ntaba, for joining us. That was excellent. We really appreciate it. One thing I like to ask, is it okay to share your slides with the group if people want more resources?
Please do. Yeah.
Data? Okay.
Any follow-up questions, let me know. Thank you for inviting
Okay,
me.
great.
Yeah.
Thank you so much, everybody. We'll see you back, let's see, September 20th for Hygiene for All. So thank you. Have a good day.